Hello and welcome to the Community Knowledge Network, brought to you by Vizient's Hospital Improvement Innovation Network, or HIIN. The Vizient HIIN supports the aims of CMS to improve patient safety and decrease patient harm through the use of proven practices across the continuum of care. Statistics show that every American adult will experience a diagnostic error in their lifetime. Healthcare providers and organizations are aware of this, and yet it still happens. On today's program, we'll talk about what the hospitals and providers can do to identify, explore solutions and strategies to keep them from repeating. I'm Laurel Whitmore, Associate Vice President of Collaboratives at Vizient. Before we begin our discussion, let's review our learning objectives for today. The first objective is to explain cognitive and systems factors that contribute to diagnostic error. Second, to identify strategies that providers can use to reduce the occurrence of cognitive errors. And third, to discuss at least one step a hospital can take to begin to address diagnostic errors. And joining me today are Dr. Andrew Olson from the University of Minnesota Medical School and Dr. Hardeep Singh from the Michael E. DeBakey VA Medical Center and Baylor College of Medicine. Welcome to you both.
Thank you.
Andrew, can you briefly tell us about your background and your interest in diagnostic errors?
Absolutely, and I'm so delighted to be here. I'm a clinician educator and medicine pediatrics hospitalist at the University of Minnesota, where I study and research ways to improve diagnostic reasoning through education and clinical practice.
Great, welcome, glad you're here. And Hardeep, welcome back to the show. Can you tell us a bit about your background?
Sure, thanks for having me again. So I'm a general internist and a patient safety researcher, and the way I got interested in diagnostic error is I was practicing in rural East Texas, and I realized there were a lot of things that we could do differently in our healthcare system. So I now generate evidence through research in practice improvement, how to influence policy, and how to improve patient care.
Okay, great. Welcome to both of you. And Hardeep, the Institute of Medicine to Errors HIIN report came out 2 decades ago. Where are we today?
So we've made some progress. We do have highly effective interventions for infections, medication errors, but the impact has been variable, mostly because of inconsistent implementation of these practices. In the last 2 decades, other areas of safety have also, have emerged, such as outpatient care. I mean, most U.S. healthcare is delivered in the outpatient setting, but we don't know a lot about what sort of things happen in the outpatient setting as far as safety is concerned. We also have health information technology that has come up as with some unintended consequences. So we need to be able to understand how is safety getting affected with the use of health information technology. And thirdly is diagnostic errors, which have emerged as a very important major contributor in the last 2 decades. Essentially, I think if I was to sum this up, the frequency of preventable harm remains high despite all of these advances.
All right, thanks, Hardeep. Andrew, what are your thoughts?
Yeah, I couldn't agree more, and I think it's striking that nearly 20 years after the Institute of Medicine report to Error is Human, we're still talking about it like it's news. And we have made substantial progress, yet the reforms called for in that report have not been universally implemented. We know that we've made, as Hardeep mentioned, some really significant improvements in things like medication administration. It's much more difficult to make a medication error in today's healthcare. We used to think it was inevitable that if you put a central line or a catheter in one of our patients that they would get an infection. We know that that's not true. We know that there's substantial interventions that are evidence-based ways to decrease harm from some of those things we do. But we're early in the infancy now of understanding what that looks like with diagnostic error and what bundles and strategies do we need to start to improve that.
Hardeep, any other thoughts?
Yeah, so I look at this as we're almost in the Bronze Age of rudimentary tool development, and now we need to move to the golden era of patient safety improvement, and we need to do a lot more.
Okay, all right, and that's what we'll talk about today. So, Andrew, how do diagnostic errors fit into the whole patient safety movement?
I would describe it in this way, that there's both much and not nearly enough being done. And similar to other things that happened in the 1990s with other areas of medication errors and wrong site surgeries and other major adverse events, we're just now beginning to really solidify our understanding of improving both the diagnostic process and the outcomes that process gets. We certainly need a better understanding of that process, though, and we need to better define the outcomes that we're trying to achieve as systems. We've come to understand how just complicated diagnosis is, and certainly things like medication errors and wrong site surgeries are all really challenging to understand, but diagnostic errors are a whole nother level of complexity. They're almost universally multifactorial. Another interesting thing about diagnostic errors is that so much of it happens in the clinician's brain, that a patient comes to me with complaints and I assign a diagnosis, and much of that doesn't ever happen in a chart. And understanding that process in a rigorous and systematized way can be really challenging. Now, we do have actually really good tools to start to assess the diagnostic process, and thanks to Hardeep and others, with validity to begin to understand how our interventions are effective or not at improving the diagnostic process.
All right, so as you've said, Andrew, this is complex. There are a lot of different ways to think about this. How are we defining it for our discussion?
Well, typically, the National Academy of Medicine has defined diagnostic error as the failure to establish an accurate and timely explanation of the patient's health problem or communicate that to the patient. That's not the most operationally useful definition, and other research studies used to describe diagnoses that were wrong, delayed, or missed. However, defining those things for both research and quality improvement purposes is challenging, and instead the field is very much moving to one of safety and actually missed opportunities.
Yeah, so in our work, we've used this missed opportunity concept. We define these things as missed opportunities in correct or timely diagnosis based on unequivocal evidence that must be present at the time the diagnosis could have been made. And we also consider the fact that diagnosis evolves over time. There's often things that are gray and not so black and white. Things change with diagnosis. There's a lot of uncertainty, so we consider those things when we call something a diagnostic error. Now, another important thing, as Andrew mentioned, this is not just only about what's the clinician's thinking. The missed opportunities could also relate to other factors, team factors, system factors, patient-related issues. So there's a lot more to this than just a diagnostic error in the mind of a clinician.
It might be helpful to even take a step back and consider what are we even talking about when we say the word diagnosis. And for here, I think it's helpful to think about a grammar lesson. Many people think about diagnosis as a noun, that is, that explanation of the patient's health problem. That would be a diagnostic error. It's a problem with that, the failure to establish that explanation. But another really helpful way to think about that, and I think the field is very much moving in this way, is to define diagnosis as a verb. That is the process used to arrive at an explanation for a patient's health problem. And like other areas of quality improvement and patient safety, understanding that process outcomes and process measures has substantial value in understanding and improving outcomes.
Okay, so Hardeep, tell us about this diagnostic process. How do we conceptualize it?
Yeah, so it's taken us a while to sort of define this. What is the diagnostic process? And we've actually increasingly moved ourselves away from just thinking about the right or the wrong of diagnosis. We want to improve the diagnostic process. So what does that entail? So think about it this. The first thing is there's a clinician and a patient that are interacting. And if you have a history, a physical exam going on, and based on the initial diagnostic assessment, you do order a test. So that's just one dimension of the diagnostic process. The second dimension is that of the testing dimension. So assume that there's a lab test or an imaging test, and that gets interpreted by somebody. There could be problems with that. So, that's the second dimension. The third dimension of the diagnostic process is that of follow-up. So you've got the test, it's abnormal. Now you need to do something about it. You need to follow it up with either the next test or the diagnosis. The fourth dimension is that of the referral process or the consultation. So as a primary care doc, I might want to send a patient to a subspecialist, and they might want to send some information back to me. So there's problems with the referral process that can go wrong, and that can lead to diagnostic error. And look at this in the center of the blue where the patient is. The patient is central to the diagnostic process and a very important part of the diagnostic process. So you really have to consider the diagnostic process in all of these 5 dimensions in order to study it, in order to make it better.
Okay, so Hardeep, can you talk to us about the factors that contribute to diagnostic error?
Yeah, so our work has generally shown that there are 3 buckets to think about what a diagnostic process might look like. Again, these are just suggestions, but they are overlapping. You can't really demarcate one from the other very well, but the way we like to think about these things, conceptually at least, is let's just say first there's individual issues. So a clinician needs to have the knowledge. There could be problems with data gathering, such as history, physical exam. That could lead to clinical reasoning, which might not go right. There's also biases and heuristics involved in the thinking process that could lead to diagnostic errors, and of course misinterpretation of tests. The second big bucket that we think about in terms of systems issues. So as most of you know, practicing medicine in a complex healthcare system involves a lot of clinical chaos, and there could be often process failures along the lines of communication breakdowns, teamwork issues, and think about all those administrative burdens that we have that could lead to diagnostic errors, right? We're always running short of time. We've got documentation requirements, quality measures that we have to sort of adhere to. Now, all of those things affect the way we think. The third is that of patient and caregiver related issues. So for instance, language issues, adherence problems, all of these factors can lead to a diagnostic error. And often it's more than one issue. It's not just one thing that can go wrong. Oftentimes it's several of these that can go wrong, and that's what causes diagnostic error.
Mm-hmm. All right, okay, so let's break this down a little bit. So as we think about the cognitive factors, how do those come into play?
So I start with the cognition as, starting with the history and the exam, for instance, right? So you talk to a patient, you listen to their story, and you form an initial hypothesis, you then order some tests. In fact, 80% of the errors that we've studied are related to some type of a failure to elicit or act upon some key history or exam findings from the patient. We often have also seen that there's some documented critical information present in the electronic health record that we might overlook. So oftentimes you might find, oh, there's a chest x-ray that was abnormal from 3 months ago that nobody really picked up. So we've got overlooking documented critical information that has been lost to follow up. We often have lack of knowledge in some of these issues. So if you haven't heard about a certain condition, that would be, a reason to have a diagnostic error. And one of the other things I want to mention is differential diagnosis, because differential diagnosis is one thing that is so fundamental to improving diagnosis. One of our studies showed that 80% of the cases that had errors in them had no differential diagnosis documented in them.
Mm. We know that differential diagnosis is perhaps one of the most important foundational skills that we teach people early on to make a diagnosis, and it's just striking how actually often that's not reflected in charts. And that's an intervention that we could start to improve today, because we know one of the most common reasons when we ask people, why did that diagnostic error occur, is they didn't think of it. And it's possible that something like a differential diagnosis could begin to start to address that.
Mm-hmm. Okay. All right. So, Andrew, you make a good point here. So how, as an educator, do you prepare students and residents to overcome some of these things?
I think we're very early in understanding the answer to that question. And I think the first is an understanding that the underlying cognitive processes we use to make diagnosis is incredibly complex. Patients can come in with nearly innumerable number of complaints, present in innumerable ways. We do very complicated things and try to assign a diagnosis of one of thousands. It's an amazingly complex thing that, as Hardeep mentioned, occur in a really complex system. So rather than just giving our learners factual knowledge about diseases, we need to give them an understanding of the process used to arrive at that diagnosis. There's also a lot of emerging evidence that we need to give them many opportunities to practice with something in multiple settings with multiple presentations. It's not good enough to diagnose heart failure one way. You need to diagnose it 3 or 4 or 50 or 60 or 80 times and get feedback. Practice, 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 feedback, feedback, feedback. As educators, though, probably one of the most important things that we can do is show our work. I remember back to math class in high school, you would turn in your paper, and if you got all the right answers, you could get half credit because you didn't show your work. And we need to say, this is what I'm thinking. This is why I don't think that diagnosis you learned or thought the patient had is right. This is what I'm thinking. This is what else it could be. We need to model the idea of showing our work and understanding and making the process transparent, opening that black box, if you will. We need to acknowledge for our learners as well that they are also learning in a chaotic system, and I'm concerned that when we teach in chaos, how much chaos do we teach? Lastly, I think we need to think about that there's incredible variability in the diagnostic process, and thus we need to expose people to lots and lots of different ways of seeing patients, expose them with things like simulation so that they can actually identify strategies to identify cases in different contexts so that they aren't prepared just to do one thing all day. The other thing is there's been a lot written in this space about the effect of cognitive bias. And cognitive bias is a major issue. We know that things like the availability heuristic and the confirmation bias and even things like representativeness all certainly play a role in diagnostic error. There's two challenges, however. Those same biases probably also help us get it right much of the time, and we would not want to do interventions to make us less right sometimes. But also, the strategies that have aimed to combat cognitive bias head on have been somewhat ineffective so far. And so a strategy about just don't be biased or don't use confirmation bias today, Andrew, are probably less effective. Instead, what we need to do is identify context-specific strategies that we can employ in each context, with each condition, with each patient, to avoid a diagnostic error. For example, a strategy that we employ as a health system to say, I don't want to miss pulmonary embolisms in the emergency department may be very different than I want to not miss myocardial infarctions in the intensive care unit, which may be again different than I want to not miss sepsis in the pediatric intensive care unit.
Okay, so Hardeep, you've done a lot of research on overconfidence. Can you share some of your findings with us?
Yeah, so we actually did a study where we recruited 118 internists and we helped them sort of solve cases. We gave them a platform, we gave them the study information. What we wanted to do was to test the alignment between their diagnostic accuracy and the confidence that they had in that accuracy. So we gave them, relatively easy cases, but we also gave them really, really hard cases because what we wanted to do was to see if their confidence drops when they're in the midst of a really difficult case, in the midst of uncertainty. And of course, we also asked them, would you like to seek help and get some other tests or call a colleague or read a book or look at a differential diagnosis generator, just to see if they needed help. And here's what we found. We actually found that accuracy and confidence were not very well aligned. And you can see that if you look at the graph on your left, which is the relatively easier cases, the accuracy was about 60%. That means 60% of the clinicians got the cases right. The confidence was on a scale about 0.7. But when you look at the right-sided graph, what happens is the accuracy drops dramatically to below 10%. But the confidence barely budges. And we call this miscalibration. Essentially, accuracy and confidence are not very well aligned. And the higher confidence that we saw, it also led to no request for additional resources. So, even when physicians needed to seek help through either consults or decision support or curbside, they didn't think they really needed it.
These results, I just think they're fascinating. Andrew, why are physicians overconfident in their decision-making process?
I think the answer is relatively simple, actually. We need to consider that the system of medical education and practice is perfectly designed to get the outcome it gets. Medical education is really focused on creating people who are really good at getting the right answer on tests. And then when we take a step back and look at decisions we make in the clinical realm, we need to say, what are the potential outcomes of a human decision? There's three potential outcomes. The first is that outcome is expected, and we'll show the diagram that says that potentially that when a human makes a decision, it's possible that the outcome is favorable or expected. If I make a decision today and I get a good outcome, I'm going to make that same decision tomorrow. Another possibility is that outcome is unfavorable, unexpected. I'm surprised. I'll make a different decision tomorrow. I'll change my behavior. The amazing thing, and a little bit scary and leads to overconfidence though, is that we treat unknown outcomes as positive. That is, we are hardwired in a psychological way to believe that no news is good news. In healthcare, this is amazingly prevalent, and we actually don't know the outcomes of many, if not most, of the decisions we make. Thus, if I diagnose a patient with pneumonia who has a different diagnosis tomorrow, I still think it's pneumonia until someone tells me. That is, being right and being wrong feel exactly the same until someone tells you you're wrong. Practice doesn't make perfect. Practice with feedback makes better over time. And we have a system right now that doesn't allow enough feedback for calibration to happen.
All right, so Hardeep, we're talking about a lot of calibration here. How do we make clinicians better calibrated?
So research from psychology suggests that one of the ways you could do that is to give feedback. And you got to give feedback both on both positive situations as well as negative situations. That means when things have not gotten right. But as clinicians, we find it hard to discuss errors and to accept our mistakes sometimes, especially when it involves something like diagnosis, which is so inherent to the way we train and the way we practice medicine. And what we really need to do is, in fact, one of the studies that I wanted to sort of mention is in clinician focus groups, clinicians are in fact fearful of both giving feedback as well as receiving feedback on cancer-related diagnostic delays. It's a very important study that sort of shows that we really need to get this feedback right. What we want to do is to conceptualize error as a missed opportunity, like I said earlier. But I would go one step further, is not just a missed opportunity, but we could frame errors as learning opportunities. Make sure that we don't assign blame. Think about what is it that we could have done differently? What is it that we can learn from this case?
And if we stop to look at how the healthcare system's designed right now, we've done all sorts of interventions to feed forward information really well. We admit a patient to the hospital. We have ways to transmit information from the emergency department to the inpatient team. We have all sorts of evidence-based interventions to transfer information between teams and hospitals. We even send discharge summaries to primary care providers. But if you look at the figure, there's also all of those yellow arrows that point back. Those are potential feedback loops that don't exist right now. That is, I as a hospitalist rarely hear from the patient's primary care provider about whether my diagnosis was right or wrong or what I could have done better. Similarly, after a patient of mine goes to the intensive care unit, I rarely, nor are there systematized ways to identify what could have been done differently. Now, we know that feedback's a good idea. And so the challenges in implementation, there's both cultural and very real logistic challenges to doing this. However, we're at the beginning stages starting to understand the best ways that we can improve those feedback loops, implement them, and improve people's behavior over time.
All right, so talking about improving behavior, Hardeep, what strategies can providers use to reduce these cognitive errors?
So one of the most important things is you really need time to think. So I think allocation of time to think and to listen to patients is really, really important. We also need to nurture skills to communicate with patients, learn about their story, and then based on that, do something in terms of better history, exam, order the next test. We also need to improve knowledge. So for instance, if you haven't heard of myasthenia gravis, you're not going to be able to diagnose myasthenia gravis if you've never read about it. We also need to manage uncertainty. In fact, when we are uncertain, we often don't know, and as our overconfidence study showed. But essentially, we need to know when to seek for help. We need to know when we're in the middle of a difficult situation and seek help when it's most needed. Improving clinical reasoning is important, as Andrew mentioned, and one of the ways that we think that this could be done is through, again, calibration. Why calibration? Because we're struggling between both underuse and overuse in healthcare. So we often think, should I order the test, in which case I might be over-testing? Or should I not order the test, in which case I might miss the diagnosis? We're also struggling between under and over all the time. And we said recently in a paper, but the best diagnostician may be the clinician who can make a diagnosis using the fewest resources, who can manage and communicate uncertainty to patients effectively, and tolerate watchful waiting when unfocused treatment may be harmful.
There's some strategies that we can do now to implement at the bedside to start to decrease some of these cognitive errors potentially, and we need to study these things. But we need to consider things like the worst case scenario. A patient comes in to me with back pain and I say, what's the worst thing this could be? Is it possible that this isn't simple musculoskeletal back pain? This works really well in a paradigm like chest pain, that I need to consider 5 or 6 diagnoses each time in every patient with chest pain so that I don't miss things when I discharge someone and say, this is not something concerning. Similarly, we need to, in our own cognition, systematize ways to look for red flags. That is, back pain with a fever is really different than back pain. Chest pain with an alteration in vital signs is really different than chest pain alone. We also, as Hardeep mentioned, need to identify and discuss ways to talk about uncertainty, both with ourselves and with our patients. And I actually think it's an ethical problem if we don't share our understanding of uncertainty with patients. If they think we're sure when we're not, that's potentially a real problem that we need to address. We also need to study all of these things and say what cognitive strategies are effective. Certainly knowledge is important, but we need to get past the most common feedback in medical education, which is read more and try harder. Instead, we need to say, what can we actually do to improve this? Because most teaching has taught on diagnoses, but not on diagnosis. That is, I learned a lot in medical school about heart failure, or sepsis, or even heart attacks. But I actually don't think I learned very much about diagnosing those things at all. And certainly, I didn't learn very much that there's potentially an error that could happen. I think one really helpful analogy here is to think about driver's ed. When I took driver's ed in 10th grade, I learned that this is how you drive safely, but accidents can happen and things go awry, and this is actually what you do to avoid them, and this is what you do when an accident happens. We need to be able to say that same thing in healthcare to understand there's an imperfect practice in an imperfect system with imperfect people, and we need to be able to respond to events and learn from those processes rather than hiding them or being scared. I think potentially one of the most important things we'll talk about today too is that it needs to be okay to say, I don't know. There's different ways of not knowing, and we're starting to understand that better. But one of the best quotes of this came from Politics, where Donald Rumsfeld said that we know what we know there are things we do not know, and we know there are things that we don't know. We actually have to address the knowable unknowns and the unknowable unknowns, and we need to make sure it's okay in your system today to say, I don't know, will you help me? I don't know if I'm right or not, and it's possible that I'm wrong.
All right, so Andrew, some of this sounds so simple, but it's a big change from where we've been. How can physicians make some of these things happen?
So I think one of the things that we need to begin to do is get ourselves out of our own automatic decision-making and stop an ability to reconsider. And more simply than it's been described as taking a time out, but I think it goes beyond that. And some of these things are questions that we could ask ourselves when we're caring for a patient, or one of our nursing colleagues, or even the patient could ask us these questions. We could ask a patient, what if this actually isn't the diagnosis that I think it is? Potentially, what if we're wrong? And I think that's a really humbling thing to share with the patient. But when I stop to consider that in a situation, often the answer says, well, it seems like we're making a safe choice here. But if we're wrong, we need to really reconsider. So opening the idea that we might be wrong. And then also, it's very clear that patients, their interaction with us, and even the conditions they have and the context in which we practice substantially improve our decision making. We know that patients with mental illness have a substantially increased burden of diagnostic errors. So we need to say, is that patient with mental illness and abdominal pain, do I need to make sure that I'm treating them in a way that considers that not everything is due to their mental illness? Same thing with patients with underlying genetic syndromes. They can have common things as well. Not everything in a patient with cancer is due to their cancer. And I think in the opioid era, we need to also consider that patients who come in with complaints around back pain or neck pain, who also are dependent on opioids, not everything's due to the opioids. And I know I've seen multiple cases of that, and Hardeep's published on this space as well, that patients often have delayed diagnoses with respect to things like epidural abscess. As in my pediatrics practice, I need to stop and consider, what if this family was treating me differently at the bedside? How would that affect my decision making? One of the most promising strategies as well at the bedside that is emerging in the evidence is the idea of contradictory information. That is, what if the thing that doesn't fit in this case, what if that really, really matters? What if I need to not ignore it or not try to say, well, in this case that doesn't apply? What if it really matters? The last thing is to really enhance the power of teamwork in the diagnostic process. Every diagnosis, from the most simple diagnosis of hypertension in the outpatient clinic to the most complex genetic syndrome, is made by a team. And we need to embrace, celebrate, and engage everyone who touches the patient in having a role in the diagnostic team.
Mm-hmm. All right, so Andrew, you just talked a lot about the patient and understanding them. Hardeep, can you talk a little bit more about patient involvement?
Yeah, so if you recollect the picture that I showed just a few minutes ago, the patient is really central to the diagnostic process. So all of those dimensions are around the patient, and the patient needs to be engaged in all parts of the diagnostic process. One straightforward example is patients should feel no news is not good news from the doctor, right? So if you have not heard about the follow-up of your test, make sure that the patients feel it's okay to just call the doctor up or call the hospital up and ask about that test result. What happened to my biopsy? I had my biopsy about a week ago and haven't heard about those results. So it's really, really important to engage patients. All health systems should do that in order to engage patients in their care. Just have this almost the culture of no news is not good news. And the last thing is learning from patients about safety strategies. So when you talk to patients about their healthcare event and the healthcare experiences, you can learn a lot. You can learn from patient complaints, from patient experiences. You can learn from talking to patients. We recently did a study where we talked to patients who were misdiagnosed. And one of the commonest themes that we learned in this work is the doctor didn't listen to me was sort of one of the most common themes that emerged in our work. There's a lot that you can learn from patients in this patient safety realm.
All right, so Andrew, what are some specific strategies organizations or providers can use?
And I think many of those strategies center around what Hardeep just discussed, which is the idea of building in systematizing listening to the patient. But I think it's also helpful to say what parallels can we learn from, and I think there's a really helpful one that I learned from a family of patients who suffered a diagnostic error in Minnesota, which is the idea of the airline industry, that when you get on the plane, there's a pre-flight briefing that says, this is how the flight's going to go. This is how long it's going to take. We're going to serve you a drink at this point. This is when you can use the restroom. And by the way, if something goes wrong, we'll tell you, and this is what to do. We need to consider that we explain the process we're going to use in engaging a patient in their healthcare. Rather than having them be a bystander, we need to substantively engage them as a member of the team, and thus we have to tell them what the process is going to look like. So if they aren't involved, if this is a patient for whom this might be a different idea, or if we're not very good at it, there's some things that we might be able to do. And I think the thing we could do today is to start to ask some questions. So ask the patient, what doesn't fit in this explanation for you? Sometimes I come up with an explanation in my workroom or we're on rounds with my residents, and I'll go and share it with the patient, and I see a look on their face and I feel like I need to ask, doesn't make sense, does it? We can also understand that patients, especially parents and caregivers, have such an experience and such an expertise in that patient's health. And thus, we're new to them often, and so we need to stop and say, what do you think about our current approach? Does it make sense? Given everything you've been through, does it fit this time? And then start to ask, what have you read about your condition?
All right, and with that, I know some providers are uncomfortable when patients come to them with their own self-diagnosis. Can you touch on that?
Yeah, so we have to get over ourselves. That is normal human behavior. We Google everything. We Google where to have dinner. We use our phone to figure out how to get a ride. So of course you're going to enter information into search engines. And certainly it's important to consider, I think, that there's two potential outcomes from that when a patient comes in with a potentially even self-diagnosis. First is that patient got the right answer. That makes our life easier. The second one is that the patient thinks they have something that they might not have. And if we don't know that and we don't address that, the patient leaves worried that they still might have cancer. I think there's also a really incredibly powerful yet subtle thing that we can do with patients who read about their conditions. Number one, we need a compliment on caring about their health and being proactive and being activated in that space. But also, ask people, what did you type in Google? One of the more common searches related to health on Google is, do I have cancer? Or could I have cancer? Patients are often scared to ask me that. And so we need to say, tell me what you typed into the box and let's talk about that. There's a few other things that we could do to engage patients in the diagnostic process. Number one is explain the idea of working diagnosis. That is, the diagnosis I give you today could change tomorrow, and that's a very natural thing. We need to help them understand that it's a dynamic and evolving process. Invite them into questioning and say, you know what, you're welcome to read about it. Here's some websites I'd love you to go to. And if there's something that doesn't make sense, please, please, please bring it up. And then lastly, we need to ensure really highly reliable safety nets for our patients to be able to follow up with us. The worst thing when you're worried about that biopsy or when you're worried about your health concerns getting stuck in a phone tree, or worse yet, going to a voicemail that's full. We need to have highly reliable follow-up systems.
All right, so Hardeep, can you touch on second opinions and how they play in here?
Yeah, I think second opinions are really important as a safeguard. So if your symptoms are not getting better despite treatment, in cases when diagnosis is really unclear, or in some cases, when the diagnosis is a life-threatening or rare condition, think about second opinions. You might need them. In fact, one of our studies, we looked to see the difference between the first and a second expert opinion, and there was about a 15% lack of concordance. So that means 15% of the time the diagnosis was different from the first opinion. Sometimes you need a third opinion because you just don't know which one is correct. So I think second opinions are important. Patients should initiate them, and also the healthcare system as well as clinicians should support the use of second opinions. We should encourage patients to get a second opinion, especially when there's uncertainty.
All right, okay, so let's shift from cognitive factors and move into system factors. Andrew, can you share what are those?
I think the first thing is to step back and say that we work in chaotic stress systems that many times value the wrong thing. I think we only need to look at an editorial that came from the New England Journal of Medicine last fall that talked about getting rid of stupid stuff. And I want to give two examples of stupid stuff. Pagers and fax machines. It's mind-blowing to me that in 2019, it's possible that your healthcare could be dependent on a fax going through or not. And my students who spend all their time using amazing technology are still learning to use a fax machine. That's cognitively dissonant and doesn't make any sense to me. Similarly, our systems have not created space for people to stop and think. They have not created that space for me to stop and cognate about what's going on with the patient. Lastly, we need to systematize teamwork. That is, it needs to be natural and expected that you're a member of a team and employ highly reliable teamwork strategies at every part of the diagnostic process.
All right, so Hardeep, how can a system start moving in this direction?
Yeah, so I think measurement is one of the first steps towards improvement. I think all health systems should get leadership buy-in, all hospitals, all outpatient clinics, get leadership buy-in and start looking at some of these cases. Try to find some of these diagnostic errors, evaluate them for missed opportunities, see what kinds of lessons and learning emerges, and then do something about it. That's a good start.
Okay, all right, great, thank you. So we visited Geisinger in Danville, Pennsylvania to see how they're identifying missed opportunities. Let's take a look at what they have to say.
Geisinger is a large, rural, integrated health system based in Pennsylvania with sites in New Jersey as well. It includes 13 hospitals, a level 1 trauma center, a health plan, as well as a medical school. There's no clear-cut outline for organizations to follow in addressing diagnostic errors. From a hospital perspective, it's essential that we address this as part of our responsibility to caring for patients.
We have the Committee to Improve Clinical Diagnosis, and the emphasis is just that, to improve clinical diagnosis, to avoid errors that could potentially happen, to educate our colleagues and ourselves.
We have probably about 20 members on the committee representing all specialties and levels of experience. We have some folks who are fairly young in their careers and others that are more senior.
We have a hotline through which anybody can convey to the committee that a diagnostic or a potential diagnostic error has been made. These can be self-reported or reported by a colleague, not with the goal of pointing fingers at anyone, but to improve patient care.
We're looking everywhere. We're looking in the emergency room. We're looking in the inpatient setting. We're looking in the outpatient setting. Anywhere these things occur, we need to find them, and we need to investigate them, and we need to learn from them. That's the ultimate goal.
I think for physicians in general, admitting that we can make mistakes, that's a pretty tough one. We've all gone through this aggressive, prolonged, competitive training process, and it's really hard to say, I don't know. And it's really hard to say, I made a mistake.
In essence, the Committee to Improve Clinical Diagnosis acts as a facilitator so that departments, divisions, and ultimately physicians are empowered and have the opportunity to reduce preventable errors and improve the diagnostic process, thereby improving the patient care that we deliver.
How can we as a team review this case and build in systems and changes so that we don't have the same problem happen again?
It's a very sensitive time for a clinician to hear about an error that they may have been involved with. So we've tried to perfect a system It has to be done in a non-punitive way. It has to be done in a collegial way so that it's really a learning experience. The key is to actually share it with those who've not experienced the diagnostic error to help them be more attuned in the future to avoid the same error. That's the whole purpose.
The main functions of the committee are to develop strategies to identify and specifically target diagnostic errors, to begin to categorize the errors so that we can understand some of the origins of errors in the clinical care process and the diagnostic process.
If it was a system problem, then the system problem needs to be fixed. If it was a problem related to lack of knowledge or a misinterpretation of a diagnostic test, then that needs to be addressed. So the problem could be systemic or it could be individual.
Diagnostic errors is not yet translatable into measures that can be paid for or that can be reported. But one of the aims of the Safer Diagnosis Learning Lab and the committee is to actually learn and provide feedback to physicians even when there is no harm.
What they're striving for is, a very noble gesture, which is, how do we work on this aspect of medical care that we don't have down, that is not completely correct, so that we do get it better.
It's difficult. It's not part of our history in healthcare to be this open and transparent about diagnostic errors. But, moving forward, there's no looking back at this. There's no way we could ever justify not doing this and not doing it well.
Okay, great. All right, thank you to Geisinger. It's always interesting to see how an organization is applying some of these things. And Hardeep, you're actually working with Geisinger on some of this work. So can you tell us more about their committee structure and processes they're putting in place?
Yeah, so one of the things they did is got leadership buy-in. So all the C-suites involved, and they're all engaged, and they're all enthusiastic about this committee, as you saw. So there's quite a lot of diverse representation on the committee. So you've got, the clinicians from emergency room and the hospital medicine, primary care, but you've also got sort of the lab folks, the radiology folks involved. So it's a very diverse committee, and what they're doing is identifying cases from various sources and then analyzing those cases for missed opportunities and see what kind of learning emerges. And what they want to do, and we're working with them on trying to develop this feedback loop, is how do you generate that feedback for improvement? How do you generate that learning? What kinds of interventions you put in place to make improvements? And one of the things we've been doing is, because the scientific evidence of how you give feedback effectively to clinicians, for instance, is not very well known, we're doing a pilot study looking to see, using existing principles, how do we do a good job in a non-punitive fashion delivering feedback to clinicians.
And we know that that feedback has to occur at every level. It has to occur at the individual level, but it also has to happen at the team level, that our team on this unit or this ward or this operating room team isn't making the diagnosis as in a way that we could do in the future. And similarly, we have to identify system-wide, where are our vulnerabilities, where are our gaps, and give feedback at the system level. Again, just like anything in patient safety and quality improvement, it's not about assigning blame. It's not about saying you're a bad doctor or you're a bad nurse, but instead saying, is there an opportunity to learn?
Mm-hmm. So Andrew, in that vein, are there steps a hospital can take to start to address these diagnostic errors?
One of the first things to consider is that despite this webinar and our work and the increasing focus on this in society, is that we still need to raise awareness that there's a problem with diagnosis and diagnostic errors happen. But yet there needs to be a second clause to that sentence, is that these errors are not inevitable. They are not unavoidable. Yet we still need to identify what those strategies are to avoid them. But again, there's hope, and I think that the people who work in this space are the most optimistic and idealistic people I know, because we really believe that we can make a difference. We need to start to implement systems, as Geisinger and others are doing, to identify diagnostic errors and learn from them, and then what key vulnerabilities in our system are exposed by that. We can do things like harnessing the power of existing data streams and follow-up calls to our patients. Can we say, hey, did the diagnosis change? And then lastly, we need to really understand what happens at transitions of cares for our patients. It is very ubiquitous in healthcare that patients transition between providers. We need to make sure information about diagnosis is transferred forward and transmitted back through every transition of care so the ball stops getting dropped.
Mm-hmm. So Hardeep, what about leveraging technology?
Yeah, so isn't it time that we start using our electronic health records to improve patient safety? Yeah, so I think we've gone through this cycle of peak of inflated expectations from electronic health records when we really wanted to, we thought that this was going to fix healthcare and fix all the quality and safety problem. There's actually something called the technology hype cycle, where after you've gone through the peak of inflated expectations, there's a trough of disillusionment. And I think we're slowly climbing out of that trough and reaching the slope of enlightenment. And what we've done in our work is we've tried to use electronic data to identify targets for improving diagnostic safety. What do we mean? Essentially, we mean a model of finding needles in the haystack. It's not possible to review every record. It's either in primary care or in the hospital or in the emergency room. But what we've done is we've developed these queries that can be put into electronic health record data warehouse that could then identify patients and alert patient safety personnel of possible adverse events, which means these algorithms will only identify the selective high-risk sample from, let's say, a data warehouse, which could be significant for a possible diagnostic error. Just one example here is, let's say a 42-year-old healthy patient gets admitted to the hospital, but 2-3 days later, they unexpectedly get transferred to the ICU after a rapid response team happens. Let's look at the patient's record to see, did we miss anything or not? Another example trigger that we use is a primary care index visit followed by an unplanned hospitalization, let's say within 10 days or 7 days, for instance. Could something have been missed in the initial visit that could signify that there was a missed opportunity? So we can only then review the selective medical records rather than review all of the medical records.
All right, so you're talking about looking retrospectively at the data we've got. What about predictive or prospective review of the data? How can we do that?
Yeah, we really need to try to do more proactive work. In fact, what we've done is we've tried to apply the same trigger model in delays in cancer diagnosis, which many of you know are not so uncommon. We had identified that several of these delays were because of abnormal findings, such as abnormal chest X-ray or an abnormal lab test that were not getting followed up. In fact, 8% of abnormal tests in one of our studies were not followed up in a timely basis. What we did was to build this algorithm-based backup system to catch some of these abnormalities in time. So when you have a patient who's had an abnormal test but they don't have a follow-up, we can identify through trigger application, we would query hundreds and thousands of medical records and identify only just a few patients who were lost to follow-up, who didn't have a follow-up on their test. So proactively making sure they don't get delays in cancer diagnosis.
All right. Andrew, how can hospitals improve diagnosis?
I think one of the first things that hospitals can do is examine and then seek to relentlessly close open loops in your system. These are open loops, like Hardeep just discussed, around test follow-up. That is, if a test is done, you need the result and you need to make sure it's followed up on. We need to close loops around provider feedback and stop saying things like no news is good news or someone will tell me if I'm wrong. We need to make sure that EHRs are as interoperable as possible, knowing that at the time of transfer between hospitals, interoperability decreases mortality. There's not one answer. There's no silver bullet here. But the strategies must include closing loops, improving safety nets. And then how do we actually practice with and harness the power of the EHR rather than practicing in spite of the EHR? I think we've all been to lots of conferences where we whine about it. We need to actually say, this is a really powerful tool that we can actually use and actually make better. And then hospitals need to identify and shine light in those most vulnerable areas of diagnosis to say, we can make this better.
Okay, and Hardeep, can you give us some specific examples that hospitals and health systems can implement?
Yeah, so I think all health systems should think about creating some kind of a centralized structure or a committee or a task force or just a group of champions, just like a structure that Geisinger had, Committee to Improve Clinical Diagnosis, to create the bandwidth to do something, and put into place some measurement strategies for learning and improvement. So identify some cases, figure out what we can do right, and now here what we mean is, this measurement is not for penalties. This measurement is essentially for learning and improvement. And the second example I want to build upon is what Andrew mentioned about closing the loop. There are several strategies out there. There's guides that have been developed on closing the loop. Safer Guides, AHRQ, in fact, has some resources on their website about how to close the loop on lab tests. One of the things we can do is as simple as figure out who's responsible for that test that was ordered. How many of you actually have a policy that states, if I, as a clinician, order the test, who is responsible? Is it me or is it my covering clinician? So all of those things need to be resolved, and process improvement can really happen very quickly once we figure out what is it that we can do right with closing the loop.
All right, so Hardeep and Andrew, you've both given us a lot of strategies on how to approach this, but it's all a lot of change. So Andrew, can you talk about that culture change?
Absolutely, and I think that all of these strategies are really great ideas, but I'm guessing that many of you are sitting there thinking, what's the culture like in my institution? And if we start talking about this stuff, what's going to happen? And I think I like this quote from Bob Feller that says, I think about baseball when I wake up in the morning, I think about it all day, and I dream about it at night. The only time I don't think about it is when I'm playing it. And this speaks to the culture of medicine right now, that we've built a system where we do a lot of medicine, but I'm worried that we don't have a chance to stop and think about that process we're using to do that medicine. It needs to be okay in your system for someone to say that they don't know everything. And we need to move from being people who are doing medicine alone to people who are practicing medicine in teams, striving constantly to improve and use the information we generate to get better, to move toward the aspirational and really inspiring goal of being a learning health system. That is, we learn from what we do, because a universal thing that people have told me who have been harmed or a family member has been harmed by an adverse event is that they say, never let this happen to someone else. And we need to commit to them to learning from this.
All right, thanks, Andrew. And so, Hardeep, can you summarize, how do we get to that learning health system?
Yeah, I think what we need to do is to create a pathway from converting all those missed opportunities that we were talking about into learning opportunities. So I think there's 3 things that we could think about is, firstly, develop a team of champions to explore diagnosis, so understand what we can do better. That doesn't mean you're going to have all the answers right up front. It just means you're going to start exploring the problem. All health systems could do that. The second thing is to determine, now, when you start exploring, you're going to find things. You're going to find information for improvement or change. We're going to need to figure out, who do you communicate this data to and how? For instance, you might want to know the lab know how to do things better, or the radiology folks, or the clinicians. And then thirdly, you're going to have to then address also the frontline concerns about diagnosis-related feedback that we talked about earlier. We don't want this to be a punitive process for clinicians that, oh, you made the wrong diagnosis, but we want to make sure that these are looked upon as constructive learning opportunities where things could be done better through feedback after we've analyzed the case and figured out what is it that we could have done better.
Okay, all right, wonderful. Hardeep, Andrew, thank you. Now, before we go any further, we're ready for you to join the conversation, and here is how you can do that. Simply type your question or comment in the question box online and click submit. And we do have some questions that have come in as we've been talking, so let's go ahead and get to them. The first question is, what are the possible drawbacks of having diagnostic error surveillance?
I can start with that. I think that the possible drawbacks are that you're going to find things and that you're going to identify problems that you need to fix. I think it creates a moral imperative in your organization. But to me, that would not be a reason not to do it. And in fact, that would be, in my view, to say we're not going to do this because we don't want to discover the diagnostic errors in our system would be a really concerning conclusion to arrive at. I think the other thing is that if you implement these things without the accompanying culture changes and leadership buy-in, it's possible that things could be punitive. But instead, if we say, I believe that you want to be the best clinician you can be, and let me give you the information that you need to do that, it's hard not to be inspired by that.
And I would just add quickly, this is going to be a resource investment.
Yeah.
So you're going to need to find those resources and the bandwidth of patient safety professionals, informatics professionals, IT people, and the leadership to make sure things are done and change happens and culture is changed. And you need a lot of resources to do that.
Okay, all right. Another question, how do you make it safe to give and receive feedback?
So I think that we need to turn to the psychology literature here to talk about the culture of feedback. And first of all, I think we need to identify that much of the feedback we get now is high acuity, low frequency feedback. That is, you only hear in the hallway conversation, do you remember about that patient? Or you get a peer review. And instead, we need to identify that probably many, many frequent tweaks is better than a few large pieces of feedback that we get over time. Secondly, it often is helpful when it comes from a peer, and it's about specific instances that says, in this case, you made this decision rather than you're making bad decisions about heart failure. The other thing is that it needs to engage the person to identify strategies to improve. So the feedback doesn't look like this. It often looks holding my hands out saying, how can I help you improve?
Yeah, we look at these things more as not as feedback sessions, but debrief sessions.
Right.
Yep. Yep.
You know, casual conversations with people about what is it different that could have been done. And sometimes things emerge that seem to be errors, and on a conversation with a colleague, it appears that they are not errors.
Right.
Okay, good. Let's see. Another question. What role does patient safety epidemiology play in this topic?
So I can start. I think diagnostic error is a part of the patient safety field. I think the numbers that we have in diagnostic error are often not taken very accurately into sort of the patient safety epidemiology literature. So if you say patient safety is getting better over the last, let's say 10 years, the diagnostic error stuff doesn't show up very well, whether it's in the inpatient setting or the outpatient setting. So I think it's like one of those missing pieces from the overall patient safety study, sort of, what we have out there. But I think slowly over the next 10 years, we're going to be able to sort of, fill that gap, if you will.
Okay. Yep. Yep. All right, let's see, another one here. I'm interested in the presenter's thoughts about decision support tools. With more automation, do we run the risk of thinking even less? Are there risks outweighed by the potential benefits?
So we could spend another whole hour talking about this topic, but I think one of the things to consider is that when we think about AI in healthcare, many of us view that the A should actually stand for augmented intelligence. How can it help us make us better? There is a role for clinical decision support. Just like nobody really worries right now that I can't ride a horse anymore. It's okay that I can drive a car. We need to think about that, but we also need to study effective strategies to implement them, and also know that right now in their current form, these tools are not a panacea. That they don't replace human cognition, but I think they are potentially an aid for us, especially in specific strategies where we're reaching the limits of our knowledge or susceptible to bias.
And remember that the decision support tools are only going to be as good as the information that we put into them. So if you don't get that history of travel to West Africa from the patient, any decision support tool that's enabling you for better diagnosis is not going to think about Ebola as one of the diagnoses.
Right. Yeah.
So,
yeah. Good. Okay, let's see. Another question. How do you view the way that peer review is used with respect to diagnostic errors?
So I have grave concerns about how peer review is executed in this country. That often it's viewed as punitive and something that's, you did something wrong. And again, it's a high acuity, low frequency event that essentially said, did you mess up? And there is a role for peer review. There's a great protection statutes for non-discoverability. That's very important. But we also need to consider that we need to move past systems that are more, and make past the systems that exist now and make systems more nimble to engage people, rather than something that in most systems, most people describe peer review as a pretty punitive process right now. Instead, we need to fix that, but also employ much more nimble and frequently usable systems to improve decision making.
Yeah, I agree. I think peer review has been one of the lost opportunities. We could do a much better job and make it much more constructive and a learning opportunity. One of the things I often get asked is, how in a peer review do you determine that, after looking at a medical record, that this is a diagnostic error, or what should have been done differently? So over the years, we've actually developed a tool called the SaferDX instrument, which can help you look at a medical record to see if there's any presence of a diagnostic missed opportunity. And we've had one version of the instrument already, and a second new version should be coming out fairly soon.
Okay, all right, okay. Let's see, we have some other questions here, but I think probably we're running out of time here. So we're out of time. If we didn't get to your question, we will answer it via email. And I want to again thank you, Andrew and Hardeep, for being here.
Pleasure.
And for sharing
Absolutely.
your insights today. Wonderful discussion. If you would like to contact our guests after the program, their contact information is here, and it's also in your handout. And also in your handout, just to note, we mentioned the Get Rid of Stupid Stuff, gross. We actually have a recent podcast that we produced here on some work that Temple is doing, so we will make that link available in your handout materials as well. I'd also like to thank the team at Geisinger for sharing with us the work that they're doing in identifying diagnostic errors. So thankful that you allowed us to come in. We hope we have given you ideas on how to continue and expand your work on reducing diagnostic errors and making health care safer for our patients. I'm Laurel Whitmore, and thank you for watching.